centers of the brain today. That's basically where we left off. So with that, whenever our oxygen demand rises, we are going to need to then make sure that our respiratory rate increases. And if our respiratory rate increases and we are sucking more air in, what else had better increase to catch all that air? Respiratory rate increases, what also has to go with it?
Heart rate.
Heart rate has to go with it. So we have both voluntary and involuntary control centers. Now your involuntary control centers, the biggest ones are going to be found in the medulla oblongata and the pons. So if you guys remember back, we'll give you an ugly brain model here. So if you give you a big old brain with the brainstem coming down, pons kind of right there. We have a couple of centers in the medulla. One that kind of sits right here. It's called our DRG. And then one that sits down just in front of it, called our VRG. So DRG is our dorsal respiratory group. No, this is in the medulla. The dorsal respiratory group controls only inspiration, and only inspiration of eupenia. So if I'm only doing inspiratory of eupenia, what two muscles am I working with?
Diaphragm, external intercostal.
So I got diaphragm, and I've got external intercostals. So if I hit those two muscles, I'm going to breathe in, right? When I let those two muscles relax, what's going to happen to me? I'm just going to expire. I'm going to breathe out, right? That's why this one is in control of eupenia. My VRG, or ventral respiratory group, for those of you that had me in AP1, I told you you're going to see these again, right? So the ventral respiratory group, this one is more geared for both inspiration and expiration through hyperpenia, which means extra heavy breathing. So what muscles inspiratory would these need to control? What are my accessory muscles for inspiration again? Okay, so SCM, good. Scalenes. Which ones?
Abdominal.
Those are expiratory.
Oh, okay.
Oh, pectoralis minor.
Pec minor.
Serratus.
And serratus anterior. But I also need to then be able to breathe out. So now I've got abdominal wall. And then a couple others.
Internal intercostals.
Okay, so internal intercostals. And the real fun one.
Transversus thoracis.
Thoracicus. So those are the muscles that the VRG is going to control. So here's a way to think about this already, guys. If I want to breathe in, I'm going to first use my dorsal respiratory group, and I'm going to go through eupenia. If I still have a higher demand for oxygen than eupenia can supply, then I'm going to go into hyperpenia, and I'm going to see my inspiratory accessory muscles kick in. And if those kick in order to breathe out, what has to help me? my expiratory muscles. Is that making sense? So it's all depending on how much you actually need in order for this thing to work. So my DRG only works with inspiratory because that's the only time when we are actually going to be active. For eupenia, inspiratory is active. Again, it's passive when I breathe out because all I got to do is let these muscles relax. If I need more oxygen, then I'm going to go into the ventral respiratory group. So I'm going to kind of spill over into the next one. And that then is going to assist me with the other muscles, the accessory muscles. So basically, as I'm breathing in, according to this dorsal respiratory group, if I need to go more, then I will spill over that stimulation and I will hit the ventral respiratory group and get it involved as well. So the next two we need to bring into play are going to be our two in the pons. And in the pons, we now have to add in the apnoistic center and the pneumotaxic center. So we'll give you apnoistic is here. Make sure I spell it right. And then pneumotaxic is up here. Now these two, because they're in the pons, also work with the cerebellum. So they're going to be coordinating this activity of what's going on with DRG and VRG. So the easiest way to say this, your apnoistic center controls your depth of breathing, and your pneumotaxic center controls your rate of breathing. And here is why. Your pneumotaxic center is going to be constantly stimulating the DRG for you to breathe in. The longer it stimulates, the more it's going to fill up that DRG and spill over into the VRG. Yes, sir?
You said that was
The apnoistic center does the depth of breathing, and it's going to constantly stimulate the DRG. We'll make this make more sense here in a second. My pneumotaxic center, controlling the rate, says, you know what? Stop irritating DRG and let us breathe out. So when the pneumotaxic center fires off, it stops the apnoistic center from messing with the DRG, and I'm going to start to breathe out. I'm going to start to exhale. So let's give you a way to remember this for a second, and hopefully it will make more sense to you guys. If you are taking a long trip and you have 3 boys in the back of a vehicle, is that a recipe for disaster, first off?
Mm-hmm.
Pretty much, right? So we got oldest boy, apnoistic center, middle-aged boy, dorsal respiratory group, or DRG, and youngest boy is VRG. Oldest boy is always going to do what? Pick on middle boy, right? Okay, so we're always, apnoistic center is always trying to stimulate DRG. Well, DRG gets tired of that, so what does he do? Messes with youngest boy, right? And who stops the whole thing? Mom or dad, depending on which one's right there. So pneumotaxic center stops all this stuff from going on. So as long as I want to breathe in, my apnoistic center will stimulate my DRG. My DRG then will start to stimulate my VRG. And I'll breathe in, and I'll breathe in very deep. As soon as it is time to breathe out, pneumotaxic center says, okay, knock off the inspiration and allow expiration to occur. Is that making a little more sense? All right, so those are your respiratory centers. If we have a problem with these reflexive actions, we are then looking at the nice little condition of SIDS, or sudden infant death syndrome. That is basically the idea right now, is that these centers are probably the issue with the sudden infant death syndrome. Now, quick question for you. with where these areas sit, what could possibly go wrong with them? That would cause a baby to have an issue.
Whiplash.
What was that?
Whiplash.
Whiplash for a baby how?
Not protecting their head.
Okay, so after they're born, not protecting their head, is there anything that could happen during birth?
Stuck in the
Spinal
birth
cord?
canal.
Okay, cord around the next possibility.
Stuck in the birth canal, maybe.
Stuck in the birth canal is a possibility. When you want to deliver a kid, what do you have to grab in order to help deliver the child?
The head. The shoulders.
You grab the shoulders. Or at least you try to grab the shoulders. Problem is, if you grab the head and you have to rotate the shoulders through the birth canal, then you're sitting here taking this kid's head and you're doing what with it? Is that going to cause trauma? Is that going to cause inflammation?
Yes.
Does inflammation tend to interrupt stuff?
Yes.
Guys, right there is my frame and magnet. That's the base of the skull. Is inflammation a big possibility here?
Mhm.
And that's one of the things they're looking at very heavily. Is birth processes going to be one of the problems that's causing sudden infant because of inflammatory problems and issues? That's not too scary.
Thanks.
Most do it well. Just don't let them get the suction cup, okay? You end up with a cone head.
That can be fixed.
Huh?
Said that can be fixed.
Yeah, time, a little pressure. No, don't whack your baby on the head. Jeez. Forceps are always fun because then you get the really cool marks on the side of the cheeks. All right. As far as other respiratory reflexes, I can say it. One of my friends had a kid this morning at 4 o'clock. It was great. The text came in at 2. Yeah, she's finally fully dilated and starting to push. I'm like, okay, you induced her 2 days ago.
God.
Broke her water yesterday morning. Like, yeah, I hope she's finally delivering. By the way, we'll stay away for a few days and let her relax.
Yeah.
All right, so with reflexes, guys, we're going to use chemoreceptors. We're going to use baroreceptors. We're also going to use some stretch receptors in the lungs. So there's a lot of different things that are going to help to control what's going on with your breathing patterns. The biggest one, or the first one, is our chemoreceptors. So in the blood, we're going to be monitoring things like the partial pressure of CO2, the pH, and the oxygen content. And again, which one of these is the most important? The CO2 levels are the ones that are the most important for us to monitor. Let's kind of go through these for a second. So our respiratory reflexes for monitoring chemicals are going to be found again in your carotid arteries and also in your aorta. So we go back to our favorite 2 cranial nerves one more time again. Which one controls the neck? Cranial nerve 9, also known as glossopharyngeal, and then 10 does vagus. That is the one for our chest. So these 2 are going to be monitoring what's happening chemical-wise. Also because right through the medulla, you guys remember from AP1, we had that central canal that was putting cerebrospinal fluid down. We also monitor the levels in the cerebrospinal fluid as well, because that's nothing more than filtered plasma. So it's another second way that we can monitor chemically what's happening with our blood and how much oxygen and CO2 we actually have. One of the things we have to watch for is a term that we're going to label CAPNIA. C-A-P-N-I-A. Please remember this term because you will see it again when we get to fluid, acid, base, and pH balance. CAPNIA deals with CO2. So if I am hypercapnia, I have too much CO2. If I'm hypocapnia, I don't have enough CO2. And according to that teeter-totter that I gave you Tuesday, if I'm hypercapnic, what is my pH doing? It's going low, so I'm becoming acidic, right? And if my CO2 levels in my blood go low, what happens to my pH?
Become alkaline.
It rises and I become alkaline. So if I'm hypercapnia, I'm looking at a pH somewhere around 7.35, 7.3, going down low. If I'm hypocapnia, then I'm looking at a pH around 7.45, 7.5. Does that make sense, guys? In my bloodstream, because again, what is normal pH? 7.35 to 7.45.
On hypercapnia, you said pH below 7.3,
7.35.
below 7.3.
So what kind of things could cause hypercapnia? Too much CO2 in my blood.
Not breathing out.
Okay, so not breathing enough. So what do we call that? Hypoventilation. So any condition that is not going to let me do gas exchange well, or even holding your breath, that is going to make me go hypercapnia. If I'm exercising a whole lot, I'm probably producing a lot of CO2. That could make me go hypercapnia. So anytime that I am in hypoventilation, I run the risk of hypercapnia. Now, one of the things that's kind of fun about the hypoventilation side, we can control this a little bit with our own nervous system and our own stubbornness. One of the ways this tends to happen is you have a kid who decides that they want something and mom and dad say no. And what does the kid usually then do? Throws a fit, and one of the ways they throw a fit is, I heard it over here a second ago, hold their breath. Is there a problem with the kid holding their breath? No, there's not.
Pass out, start breathing around.
Here's why. That's exactly correct. If you have a child that says, I'm going to hold my breath until I turn blue unless you let me have this, you say, go for it. Just see how dedicated they are.
Oh my God.
And so if they hold their breath and they start to turn blue, if they're turning blue, what's happening to them?
Lack of oxygen.
So they have a lack of oxygen. What do we call that?
Hypoxia.
Hypoxia, and they're going to turn blue, which is turned cyanotic. So they still decide they're going to hold their breath. Eventually, what's going to happen to them? They're going to pass out, right? And as soon as they pass out, what's going to happen? They're going to hit the floor. Their manual stubborn override of breathing is now gone, and they're going to do what? Breathe on their own. When they come to, how are they going to feel?
Headache.
Like crap. Are they going to try to do it again?
Probably.
No. Most don't. I'll give you a case in point. One of my daughters did this years and years ago in Walmart, which I don't say do this in Walmart because you're going to have people freaking out on you. But she decided she wanted a candy bar. She was misbehaving. I said, no. She said, well, I'm going to hold my breath until I turn blue. I said, go for it. Smurf yourself. So she's standing there, and she's starting to turn blue, and people are freaking out. And she's still turning blue, and people are freaking out more, and all of a sudden, boom, she's gone.
Oh, man.
And then it's like, everybody panics. No, just give her a second. She'll be fine.
Oh my gosh.
She's like, what'd you do that for? You did. You got a headache. No kidding, Sherlock. Nice job. But now when she tells me she can't do something, I said, oh, yes, you can. Here's why I have proof. So you can hypoventilate on your own and hold yourself if you're stubborn enough and dedicated enough until you actually turn blue, pass out. But then your normal respiratory things are going to kick in. Because if I have been holding my breath and I have passed out, now all of a sudden my reflexes kick in and say what? I got way too much CO2 in my body because I've been holding my breath. I haven't been blowing that off. I've got no oxygen in my body. So my pH is really low. So now what do I got to do? Blow off that CO2, so I got to breathe and bring myself back. So my normal chemoreceptors are going to kick in, and I'm going to start to breathe really quickly and blow all that stuff off, take back in the oxygen. If you hyperventilate, you're going to be blowing off all your CO2. So you're going to become what? Hypocapnia. So now my pH is going to rise. So if you have somebody who's hyperventilating, what do you do for them?
Give them a bag.
Be careful what you say. You do give them a bag, but what kind of bag? What was that?
Paper.
Paper. Why paper? Why not plastic?
Well, you need some airflow to go through.
Because the plastic will get sucked in. And now you got a bigger problem, because now you got obstructed air. Yeah, you don't give them the Walmart Piggly Wiggly bag, okay? You do ask for paper at this point. And then they breathe in and out of the paper bag. And what are they doing when they breathe in and out of a paper bag? They're reblowing back in their own CO2. So now all of a sudden, my CO2 was low, my pH was high, so I reintroduce that CO2 by making them breathe it back in again. And I lower everything and bring it back to normal again. So I balance myself out. And as you start to blow back in CO2, what happens to hyperventilation? You actually slow down your breathing rate because it calms you back down again. Is that making sense, guys? Or you can just drug, whichever way you go. What was that? Do not slap them, okay?
I said a little bit of verse.
Our baroreceptors are also going to play a role here. So when blood pressure falls, respiration is going to increase. Why? My BP is dropping. Why do I want my respiratory rate to increase?
Get your heart rate back up.
Because that's going to pump my heart rate faster. And if heart rate goes up, what's going to happen to blood pressure? It should go up because now I'm moving more blood. If my blood pressure increases too high, now what do I want to do? I want to slow down my breathing and slow down my heart, so hopefully that blood pressure starts to drop. Now there is another way that you guys can cheat. So it used to be that when you wanted health insurance, they sent out somebody to do a little check on you. So the person came in, they did blood pressure, they did all this stuff, see if you were okay. Well, there was a way to actually lower your blood pressure temporarily. Does anybody know this way? This little trick? Put your finger over your eye, gently push in. Because what are you doing? Increasing the pressure in your eye also then increases the pressure in your bloodstream. So now my blood pressure rises, which means what's going to happen to me then? My heart's going to drop in its rate, and my blood pressure will then summarily drop as well, temporarily.
Oh.
So you got to time it well. That way your blood pressure drops just as you're getting ready to get your blood pressure. We have a couple of reflexes in the lungs that are going to be preventative for you. One is what we call the inflation reflex, the other is the deflation reflex, and they're all part of the terms called the Herring-Bauer reflexes. Please highlight Herring-Bauer, guys, because it almost always shows up in your final exam. If I try to breathe in too much air, and I keep breathing in and in and in, my chest is expanding, my lungs are expanding. If my lungs hit the ribs and hit the spinal column, what could possibly happen? Just like a balloon that gets too big, it goes pop, right? So we have an inflation reflex that basically says, if you try to overexpand your lungs, before your lungs are going to burst inside your chest cavity, we're going to force you to blow out. That's the inflation reflex. The deflation reflex is a little more along the fun side. This one says, okay, if you're going to try to blow out all your air and actually collapse your lungs, then we're going to force you to breathe in. Now this one really comes into play, guys, if you are sitting there and you're giving a birthday party and you're on balloon 100, the last balloon that you have to blow up, and you've been blowing balloons for the last hour. Are you a little tired of blowing up balloons? Yeah. So what are you going to try to do with that last balloon? Not pop it.
Give it to somebody
You're
else.
going to try to get it done. So you're sitting there with your last balloon, you're going, keep trying to blow that sucker up. If you deflate your lungs too much, what's going to happen? Your lungs are going to go, no, I'm not letting you collapse, so I'm going to breathe in. And if that balloon is right here, what could happen? Now I got obstructed airway again. So we don't ever want to go into these two because they're both going to cause issues for you, especially the deflation one.
Just a second.
Just a second. 1001 seconds up.
Oh, yes.
All right, let me know when we can move forward. So inflation just protects the lungs from overinflating, so you will then breathe out. Deflation protects the lungs from collapsing so that you breathe in. So basically, these reflexes are named in opposite of what you're actually going to do. Are we free? Okay. You also have reflexes against things like vapors, toxic irritants, or mechanical stimulation. If you breathe something in like a particle or a bug, what are you going to probably do? You're going to cough. You may sneeze, especially if it's around allergen time. And you're definitely going to have what we call a laryngeal spasm. Is your larynx going to squeeze? Yeah, it's going to try to decrease the hole so that nothing else can get in there. So things like chemical irritants. You open up a little bag of a toilet bowl cleaner or a hot tub chlorine tablet. You get that poof of chlorine coming up or bleach. Is that going to irritate your throat for a second? Yes, you're going to feel that tightening. For those of you that have had the pleasure of being around things along the lines of, let's see here, what's the fun gas? Now blanking. Gas we use to control crowds.
Tear gas.
Yes.
Tear gas. So if you were in the military and you got to get locked in that nice little box with your mask on, that then they say, okay, remove the masks and drop a couple canisters in there. Was that a joyous time in there?
Not really,
Why not?
because it hurts.
Because what's happening? Everybody's coughing because you got a chemical irritant, toxic vapor. Everybody's sneezing. And because your body is trying to get that toxic chemical out of your mucous membranes, is there a lot of mucus flowing? Yeah. Is there mucus flowing to the level where people are going to vomit? Yes. So after they remove everybody and everybody comes stumbling out with puke on them or snot everywhere, things like that, there's two drains usually in the bottom of that thing, and they take a fire hose and that's how they clean it up for the next group coming in. That is an extreme example of how your body is going to respond to toxic vapors, chemical irritants, things along those lines. One of the things that you're going to try to do is apnea, a temporary stoppage in breathing. Most of you guys know apnea by what? Sleep apnea, right? It's the most common one you hear about. So you're sitting there in bed next to a significant other, and they're doing the nice little, and then you don't hear anything for a moment. What usually follows?
Hey.
Hopefully not a slug in the chest. More of the bear comes out, right? The next breath is nice big loud one. And that tells you that there was a temporary stoppage in breathing. But we also have control of apnea as well. Because this is any temporary stoppage. Gentlemen, when you get really mad and pissed off at somebody, what do you tend to do? Do you grit your teeth and hold your breath? Yeah, because you're sitting here going, and you're not breathing for a moment. I'm going to pick on you ladies now. Pick on the guys first, and I get to pick on ladies. Ladies, if you are watching a Hallmark movie, and it's getting to that point where the hero and heroine are going to kiss for the first time, what happens?
Heart races. I'm like, oh
Apnea? We hear that little moan. So that is also an apnea part. If you're sneezing or getting ready to sneeze, what do you usually say? Someone's like, huh? Huh? Achoo. So you get a temporary stoppage in that breath pattern. Same thing with coughing, because if you're going, that temporary stoppage is going to be another attack of apnea. So apnea is actually used as a way to protect the lungs so that we don't get more stuff down in them. And then voluntarily, you can control it by emotional stress. So if you're really all stressed out, you're going to change your breathing rates. If you're in parasympathetic mode, you're relaxed, your breathing rates are going to change. If you are anticipating that you're going to have to do some exercise or run, your body will actually pick up its breathing rate to get more oxygen so that you are ready with more energy for when you're about ready to start to exercise. So one of those nervous things that happens right before everybody goes in games or practices is you actually see them start to breathe faster right before, so they're building up energy so that way they can perform better. For respiratory changes with birth, before birth, there was no air in the lungs, right? Because where were you? In mom's womb, and you're surrounded by what? Amniotic fluid. So we're not exactly breathing for ourselves there. So most of our pulmonary blood vessels are collapsed or at their minimum just to keep the cells alive. But as soon as we are being born and we're in the process of delivery, the placenta is going to break off and separate. That means now we've lost our blood connection with mom, so we're not going to be able to steal mom's oxygen away anymore. What's going to happen to baby during that process? Baby's oxygen levels are going to drop. The CO2 levels are going to rise, aren't they? Baby's going to start to become a little bit acidic. So as soon as baby gets to a point where they're not squeezed anymore, they're now exposed to the outside world. High pressure there, low pressure in here now, because we've now expanded the lungs. Air is going to start to rush into baby, and then baby is going to start to take its first breath. With each successive breath baby takes, more and more alveoli are going to start to expand and pop open because of the surfactant. And as that baby continues to breathe in, and the baby gets their lungs fully expanded and gets more of the liquid out of the lungs, then we're going to be able to see the baby's oxygen levels really rise. Again, there are things that are going to affect this respiratory system. If your elastic tissues are going bye-bye, so if you're starting to get things like rib cartilage calcifying, is that going to help you to expand your chest much? No. And it's not going to pull it back in if you do expand. Arthritic changes, especially stuff of the back and the ribs, so any type of osteoarthritis of the thoracic cavity, or compression fractures in your thoracic spine. That's going to all lower this capability. And then wonderful things like emphysema. Now I know they pick on smokers for emphysema, but can you get emphysema from other ways? Absolutely. And what is basically emphysema? Alveoli that have blown apart. So now you have holes in your lung. You've lost surface area. Are you going to be able to do as much gas exchange? Not at all. So with that, your book gives you this really fun little diagram, and they pick on smokers heavily. So, if I can find, there it is, kind of hiding back here. For all of you that are age 25 right now, that is what we consider your best breathing capabilities. So you are at 100% efficiency right now. As you age, if you do nothing to damage your lungs whatsoever, you're still going to have deterioration of connective tissues and elastic tissues. You're still going to run into things like osteoarthritis, and rib cartilage is going to calcify. So you're going to very slowly see a reduction in your breathing capability. Now, if you add to that something else, like smoking or high particulates in the air, things like that that you expose yourself to, you're going to see a much faster decrease. If you stop doing whatever it is that's causing your lungs problems, your body, thanks to the nice little dust cells, those alveolar macrophages, will clean up the debris in your lungs and you will return back to a normal loss of function. Will you ever regain what you originally lost? No, because once it's gone, it's gone. If you don't stop, at some point you will reach a level around 30%. That is now considered a disability. So now you're starting to look at things like nasal canaliculi for new airways. You're going to carry oxygen packs around, things like that. If you then decide to stop, because once tragedy kind of happens, we start to think about it a little bit, you'll return back to a normal rate of decline. If you still don't stop, at some point you will hit a disability level that your body will not be able to support itself anymore. And then that is going to result in death. Is that followable, guys? Okay. That is the end of the chapter, which is really kind of nice because it's 9:46, so that's a good time to take your first break. When you guys get back here, we'll see you right around 10 o'clock. I will have your small group discussion ready for you guys to work on, so break up into your small groups.